Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, our monthly TV program about the events, happenings, and people at your community hospital. We're going to change things up a little bit this month, a slightly different format, and rather than interview all together, we've got three of our doctors who will be speaking with you. And just as a little bit of background for this episode, I had an opportunity to meet with one of our neurologists, Dr. Olga McAbee, who you'll meet with in just a second. And we were talking about the upcoming holidays, and Dr. McAbee was talking about stroke, recognition of stroke symptoms and stroke prevention. And she decided to talk in terms of if only my patients would think about what they could give me for the holidays, it would be looking for more of the symptoms of stroke early on. And that turned into an idea about bringing three of our doctors together to discuss some of the medical technologies, diagnostic techniques, and opportunities for health improvement that the doctors wish you would take advantage of as a present for them in the coming new year in order to help you have a better life and a life filled with prevention and wellness. And so we decided to invite three of our doctors and talk about what are the gifts that you could give our doctors to help you in your quest for a healthier life. And now I'd like to introduce the three doctors for this panel. Dr. Olga McAbee, who's a neurologist and the director of our stroke center. Dr. Kris Naso, who's a gastroenterologist. Dr. Edna Kapenhas, who's a breast surgeon and the medical director of the Ellen Hermanson Breast Center at our hospital. I hope you enjoy this discussion, and I'll be back at the end of the show.
Thank you, Bob, for so great introduction. I am Olga McAbee. I'm neurologist and stroke director at Southampton Hospital. And today I am with my two colleagues, Dr. Edna Kapenhas. She's our breast surgeon and medical director of our breast center. And Kris Naso, he's our gastroenterologist. Today we are going to talk about our wishes for our patients for New Year. I had this idea when I was coming to emergency department and I saw stroke patients who came to emergency department too late. And my wish was, I wish you could come earlier. What I'm going to talk today about stroke, that everyone should realize that stroke is real medical emergency. Some people call stroke as a brain attack. It's the same as heart attack. Stroke happens when blood flow to the brain is interrupted. It's interrupted because of clot in the blood vessel or because blood vessel bursts and leaks, causing blood to spill into the brain or surrounding tissues, causing brain tissue to die. As stroke goes untreated, every minute counts, because every minute our brain loses approximately 2 million cells. That's why it's very important if you or somebody near you might be having stroke, to come to emergency department as soon as possible. Don't try to lie down, don't wait hoping that symptoms will go away. Call 911 immediately.
So if you had your wish for your patients, what time would you say is the best that they should get there? What is the minimum amount of time that you would love to see your patients at the hospital?
As I mentioned, stroke can be caused by blockage of the blood vessel of the brain, by clot or by bleeding. There is a treatment for that. If patient has a bleed in the brain, patient can get emergency surgery. So patient should come as soon as possible. As patient had blockage in the blood vessel, this type of stroke is called ischemic stroke. There is treatment. We give this patient's medication, which is called TPA, or tissue plasminogen activator. We also call this medication clot buster. And this medication works better if patient comes within 3 hours of the onset of the symptoms. That's why it's very important to know when you have onset of the symptoms. Sometimes we extend this window to 4.5 hours. But as I mentioned before, every minute counts.
So you would really even like them sooner than 3 hours?
Absolutely.
I mean, every minute sounds like it makes a difference.
Absolutely. Because every minute can make a big difference between disability or full recovery, between life or death. There is very simple test that everyone can do. It's called FAST. Ask person to smile. If one side of the face droops, it can be sign of the stroke. Ask patient or somebody next to you extend their arms. If one arm is drifting downward, it can be sign of the stroke. Ask person to repeat their name or say a simple sentence. If speech is strange or interrupted, it can be a sign of the stroke. Call 911 because time is matter. Usually, if patients have stroke symptoms unilateral. One side of the brain controls the opposite side of the body. And also, I want to emphasize that onset of symptoms of the stroke sudden. If somebody has sudden onset of weakness of one side of the body, facial droop, weakness of the arm or leg, sudden numbness. If somebody has sudden onset of speech disturbance, inability to speak, sudden onset of vision loss, sudden onset of dizziness, loss of coordination, sudden onset of headache that they never had before, it can be sign of the stroke.
So you'd rather patients come to the hospital and not be having a stroke, but get there soon enough so that they can make that decision, as compared to, oh, I'll wait till the morning, it'll probably go away. Because at that point, it sounds like it's going to be too late.
Absolutely. Also, don't try to drive yourself. Don't call a taxi. You need to call 911 because paramedics can assess your condition and call emergency department. So emergency department will be ready to take care of you as soon as possible. Unfortunately, some people wait too long thinking that symptoms go away, and in this case, damage of the brain occurs, and the probability of recovery would be questionable. Some people have lifelong recovery. That's why it's very important to come to emergency department as soon as possible. Stroke occurs to almost 800,000 people in the United States. It's fourth cause of death, but it's #1 cause of disability. Luckily, 80% of strokes are preventable. And changing your lifestyle and taking care of conditions that can cause a stroke can make a big difference. Making healthy choices, eating right, having plenty of fruits and vegetables, exercising, losing weight, stopping smoking, drinking in moderation can make a big difference. Also, if you have certain conditions, getting these conditions under control is very important. Getting your blood pressure under control, diabetes, cholesterol, making sure that if you have irregular heartbeat by the name of atrial fibrillation, you get the right medication for that, can prevent most of the strokes. I wish you well in the coming year. I like my job and I like my patients. If you come to emergency department, we'll take good care of you. But I wish you really long life, happy life, long years of well-being. I hope you learned something about stroke first symptoms and how to prevent stroke. I wish you Happy New Year. Now, I want my colleagues also to make their wishes, and I want to introduce my colleague, Dr. Edna Kapenhas. She is board certified in the surgery. She is breast surgeon and she is medical director of our breast center. Please, Dr. Kapenhas.
Thank you, Dr. Maccabee. Thank you for that comprehensive review. I certainly learned a lot from it. What I wish for my patients for the new year and years to come is to know that early detection of breast cancer actually saves lives. The earlier the stage of the breast cancer at the time of the diagnosis, the higher the cure rate. Over the years, we have had relative decrease in mortality rate of breast cancer patients, and we can actually contribute that to the increased usage of screening mammography. Mammogram can pick up lesions and changes in the breast that can be cancer actually years before it becomes physically symptomatic. Whether it's a palpable mass or changes in the breast, mammogram can pick it up, like I said, years before. In general, we recommend mammography to start at age 40. That's for asymptomatic patients. That's if they don't have any complaints, no symptoms. We start at age 40 and then yearly after that. In patients that have dense breasts, dense breast appears white on mammography. So it can hide lesions and you won't be able to see it. The radiologist will have difficulty seeing it, if at all. So in those patients with dense breast, we also recommend sonography. In patients who are high risk, and that could be due to family history or if they have a genetic mutation for breast cancer, whether it's BRCA1 or 2, or there are several other different genes that increase the risk of breast cancer as well as ovarian cancer. In those patients, of course, we look at each individually and we may add different things. So in those high-risk patients, we actually recommend yearly MRIs as well, and in addition to their screening mammogram. And what I like to do, I like to alternate those with their mammography at 6 months intervals, so that every 6 months they're getting either a mammogram or MRI.
This would be for the high-risk patients?
For high-risk patients, correct. And in patients who have family history, we also recommend to start mammography 10 years younger than the first-degree relative that was diagnosed with breast cancer. So if the patient has a first-degree relative, a mother, sister who was diagnosed at age 45, the patient gets started at age 35. So my wish, oftentimes patients, some patients say, well, mammography hurts because of the compression. It really is not that painful. And the advantages of getting a mammogram as compared to not getting it, obviously it outweighs the disadvantages. The couple other things I just wanted to touch upon is self-breast exam, monthly self-breast exam. Even though the current recommendation kind of discourages against doing self-breast exam, I still recommend it to my patients. I tell them that it's a good idea to do the monthly self-breast exam simply because they should be familiar with the shape and the feel of their own breasts. So if there's a change from 1 month to the other, they should bring it to their doctor's attention. And it's been shown that if a woman was to develop breast cancer, those who do monthly self-breast exam tend to pick it up at a smaller size than those who don't. And we know that if we pick it up at a smaller size, they're less likely to need more aggressive treatment like mastectomy or chemotherapy, and more likely to have a cure rate. However, having said that, there are other things that we take into consideration other than the size of the tumor or the lymph nodes, whether the lymph nodes are affected or not. Of course, we take into account the biology of the tumor, which is extremely important as well. But in general, this lower the stage of the tumor, the higher the cure rate, and the likelihood of less aggressive treatment.
And then you spoke about high risk. I'm going to talk a little bit about high risk and a little bit about colon cancer. What would you consider your high risk patients? What's their family history that indeed makes them high risk?
Well, we have different tools that we can use to see, one of the risk assessment models. There are various tools we can use, and it basically can give us two numbers. It gives us a 5-year risk. What's this patient's 5-year risk of breast cancer, and what's their lifetime risk of breast cancer. So in general, if their 5-year risk, if it's greater than 1.7%, again, as they get older, their 5-year risk increases. So you really have to look at the individual patient. But in general, if their lifetime risk is greater than 20 to 25%, then they are considered high risk, and we add that MRI. Now, if someone is BRCA positive, the breast cancer gene, either BRCA1 or 2 positive, they automatically add significantly higher risk for breast and ovarian cancer. If they have family members, either multiple family members, or they can have a first-degree relative. A mother, for example, was diagnosed with breast cancer at age 35, 40, that's a red flag for me. If they have male breast cancer, my father had breast cancer, that's actually a red flag. That's actually one of the indications to get genetic testing, to see if, was that a genetic thing? Because male breast cancer is extremely rare. Less than 1% of all the breast cancer is male breast cancer. So that's a red flag. Or high risk if somebody had radiation to their chest for lymphoma and they got mantle radiation, they are between the age of 10 and 30. Now they're at higher risk for developing breast cancer. So there are various things that we take into consideration to see, well, you consider high risk.
Is it genetic testing is only for people who are high risk, or if you have one member in your family, should these people be genetically tested? Because it's genetically tested seems to be a wave that's kind of taking over.
It also depends. Yeah, it also depends. I think on insurance companies. Obviously, they have different criteria they look at. Like if I have a patient who was just diagnosed with breast cancer and she's younger than 50, I would send her for genetic testing. That's an indication
Everyone.
to get tested.
Under 50.
Under 50, invasive breast cancer, I send them for genetic testing. If a woman has a mother, a very, premenopausal breast cancer, the mother was diagnosed with premenopausal breast cancer, I would send them for genetic testing. Now, that doesn't mean the insurance is going to let them have it. Some of them say, well, you're going to have one more family member, or no, you're not the one who was diagnosed with breast cancer, so we're not going to approve it.
Right.
So it's a very individual thing.
Dr. Kapenhas, maybe you could tell our patients what are clinical manifestations of breast cancer?
So the clinical manifestation of breast cancer can be, again, different. It could be different in the texture in the area of the breast. It could be firmness. It could be a discrete mass. It could be ridging or thickening. Or some patients may show up. I have had patients who have lymphadenopathy under their arm and nothing in the breast, papilla in the breast, and that's how they manifested their breast cancer.
Great talk. And now we'll let our gastroenterologist, Dr. Kris Naso, to talk about colonoscopy and how colonoscopy can save life of the patients. Dr. Naso is board certified in gastroenterology, and he's our gastroenterologist here in Southampton Hospital.
Thank you, Olga. Personally, my wish would be everyone should get their screening colonoscopy. Everyone starting at the age of 50 who's at average risk. If you have a family member similar to breast cancer, we start 10 years earlier. So if there's a family member at the age of 50, we would start at the age of 40. Another group of the population is African Americans, where the average, we start screening at the age of 45, something that's not well known. But we start at the age of 45 for all African Americans, routine screening. It's unfortunate that people are not getting their screening because it's a curable disease. We could pretty much wipe out all colon cancer if everyone got their screening exams. The exams are usually once every 10 years without a family history, once every 5 with a family history. And again, the family history is usually first degree, mother, father, brother, or sister, unless you have 2 second-degree relatives, aunts and uncles. then they're at higher risk, and those people we'd be seeing at every 5 years. It's unfortunate, but the vast majority, if not the majority of cancers that I see are patients in their 60s and 70s who've never had a colonoscopy. People who are getting them in their early 50s or younger, and then you periodically see them, you'll find polyps, but you won't find advanced cancer. And the cure is so much more, your cure rate is so much higher when you get these polyps out at the younger ages, at their, before it has an advanced disease. The so-called polyp cancer sequence, it's felt that the majority, if not all, colon cancer starts as a benign polyp, and then usually within 10 years is now developed into cancer. Well, if you're periodically getting your colonoscopies and you're getting these polyps out, you're not developing cancer. And we're actually starting to see now that for the first time, I think it was the last 3-4 years now, that we're seeing a decline in colon cancer. It used to be or it still is actually the number 2 cancer in the country behind lung cancer, except for women with breast cancer. Breast cancer in women is higher than colon cancer. But we're finally starting to see a drop-off in cases because of screening. So these patients who would have gotten colon cancer now had their colonoscopies 10 and 15, 20 years ago are not developing colon cancer. So we're finally starting to see a drop in the last 3 to 4 years. I have seen an increased amount of patients who are able to get the colonoscopy because of the Affordable Care Act. That's been one good thing that's come out of that. Because a lot of people couldn't afford to have the exam. And so as insurance has gotten easier for people to get, I'm seeing more and more people get their colonoscopies. But if I had a wish for everyone that they should get it, the idea of putting your head in the sand and they're afraid of what they're going to find, I'd be afraid of what I didn't find, right. Because I didn't do it. So for me, that would be the way to go. I mean, it's sad to see when you hear of patients dying of colon cancer or of having advanced colon cancer because they haven't had their first exam till the age of 60 or 70 or even 80. I'm seeing a lot of individuals now because it's becoming more and more mainstream, getting their first exam in 70s, and a lot of times they'll have advanced lesions. So it's unfortunate, but.
You mentioned for African Americans you start at 45. Mm-hmm. Is that because they tend to develop cancer earlier? Yes,
they have a increased risk, just however it is, the reason for it, but they're more likely to get polyps at a younger age.
Without any genetic
Without any genetic, right. So we start at 45, average risk for African Americans, and for everyone else we start at the age of 50.
And do they tend to have more, when they develop colon cancer, do they, stage for stage, do they tend to have more aggressive cancers?
They can, yes, they can.
So it's sort of like breast cancer, so it's
very similar, yeah. It is. And unfortunately, a lot of folks aren't aware of that, aware of that increased risk in the population.
Kris, what are clinical symptoms of colon cancer?
Well, that's the thing. You don't really want to wait for symptoms because very often when you waited for symptoms or you have symptoms, you have an advanced lesion. Because the vast majority, if not all polyps, really don't have symptoms, other than possibly if it's close to the rectum, you might see some bleeding. But the vast majority of polyps, even large polyps, have no symptoms at all. But if you do have cancer, the symptoms can be pain, usually constant pain, anemia, because you've been losing blood from this lesion. Usually, most colon cancers have been there for years. This is a slow-growing process. Not all cancers, colon cancers are slow-growing, but the majority, far and away, take years to develop, and they've been there for years. And that's the nice thing, that we have this long window to try to get these cancers or get these early tumors before they're true cancers, these early polyps, before they develop into cancer. So when it is advanced, you'll see bleeding, you can see pain, you can see a change in bowel habits, not something that comes and goes, but consistently different. Well, last week I was a little bound up. No, this is something that's going to continue because the lesion is there all the time. So bleeding, anemia, pain, those are the main ones. But again, I would wish that we don't see those symptoms.
Absolutely.
We see the person who feels fine. And that's the problem, because people say, well, I feel fine, why do I need to go to the doctor? But that's the point. We want to get you, just as you're getting your mammograms, right. You want to get them while they're feeling fine, because Correct. You'd like to get these lesions before they have the symptoms, before they have the puckering of the skin and things like that. So that's the thing. We don't want to wait. But those are the symptoms if indeed, they occur. Those are the things that concern us. Those are our red flags.
Now, in fact, I'm sorry. Is it Is it true that when they develop the symptoms like obstruction, like obstructive colon cancer, that by itself is a pretty bad prognostic?
Yeah, usually at that point it's pretty far advanced. I mean, it all goes staging. Our staging is the degree in which it has invaded through the wall. And the idea is you want to get that polyp out before it has invaded the wall. So if you can just scrape the polyp, is what we do, scrape that polyp out, you know, even if it had cancer on the tip, like very often I'll tell people, a polyp is like a maple tree, where the leaves are the tumor and the trunk is the stalk. You cut the trunk, you've got, and even if the cancer is on the top of the tree, so to speak, it's a cure, you're done. But then when it starts to go through or even cause obstruction, goes through the wall, then into the lymph nodes, then you have advanced cancer, and then we're looking at chemotherapy, and your survival rate dramatically drops.
Is any kind of diet can prevent development?
There's some idea that possibly aspirin, baby aspirin, may decrease risk. There's never been really good studies to show that the healthy diet makes a difference. It was a very large study years ago up in Boston, 45,000 nurses had a high fiber diet versus no, and there was no real main difference. Do I still recommend it, both from a heart point of view and from a colon point of view? I do, but the studies don't really support it. So really screening is the main way to stay out of trouble.
Now, not every polyp is cancerous, correct?
The vast majority are not. The vast majority are not.
But does every polyp turn
It's felt
into?
that every cancer probably comes greater than 95, starts as a polyp, benign
Okay.
polyp. But not all polyps will go on to become cancer.
But
And
we
we
don't know
stop
which-
screening between 75 and 85, depending on if you've had a lot of polyps along the way and you're in good medical condition, we might go all the way to 85. But if you've had a couple of colonoscopies, no family history, and you've had a few colonoscopies, we probably stop at 75. So.
Well, it's a great talk. Thank you for both of you. I hope all our patients learn a lot about the first signs of the stroke symptoms and how it's important to come as soon as possible to the hospital. And you can prevent stroke by changing your diet, by exercising, losing weight, stop smoking, stop drinking, and also taking care of your medical conditions. You also, I hope, learned from great talk of Dr. Kapenhas about importance of screening mammogram, and from great talk of Dr. Naso about how it's important to have colonoscopy, screening colonoscopy. We wish you all Happy New Year and many years of well-being.
Happy New Year.
Thank you.
Thank you, Drs. Maccabee, Naso, and Kapenhas, for your health tips and how to lead a healthier life, and simple tips that people can follow to enjoy life in 2016. If you'd like to make an appointment with any of the members of the panel that spoke with you today, we will run their names and telephone numbers on the screen during the credits, or you can check our hospital website at southamptonhospital.org. Finally, I'd like to thank everybody for participating once again. I'd like to thank our friends at CTV for producing and airing the show in Southampton, and our friends at LTV for airing the show in our East Hampton communities. Thank all of you for watching. And also, if any of you have questions, ideas for future shows, or would just like assistance navigating the healthcare system on the East End, please feel free to give my office a call at 631-726-8555. Hope you have a healthy and happy New Year in 2016.